But the question you sent to me earlier was a symptomatic question. It was a woman, I believe, who had had transverse myelitis diagnosed last summer in August of 2016, and she indicated she was taking a drug called Lyrica or pregabalin twice a day. What she said was that she was having sensory changes in her legs and her feet and a lot of muscle stiffness, and asked if there was any better drug for those sensory disturbances, and was I aware of something called myofascial release, and whether or not myofascial release could help with these symptoms. So it's important to understand the sensory aspects and the stiffness that goes with transverse myelitis. So it turns out that those upper motor neurons that I pointed out and spent so much time belaboring the point over and over again, a lot of the signals they send down the spinal cord are actually stop signals to the lower motor neuron. So if you lose the connection between the upper and the lower motor neuron is unbridled to just throw a party and tell the muscles to contract and tell the muscles to increase their tone. So the stiffness that somebody has is because their lower motor neuron is no longer regulated by that upper motor neuron, so the muscles get tight. So there are lots of ways to try and loosen up the muscles. Myofascial release can help, but it tends to be temporary. People tend to have it done and say, oh, I feel great for 30 minutes or an hour and a half, but slowly the stiffness kicks back in. Some people use acupuncture and can get some longer relief. Stretching plays a big role. There's a reflex arc between your muscle and the spinal cord. So the more you stretch out your muscle manually, the less stiffness you'll have. But in the end, sometimes we have to use medication. There are several medicines that are used pretty routinely in the United States for this. One is baclofen in the United States, tizanidine, another medication called dantrolene, and sometimes some medicines that are related to Valium or diazepam are used to manage the stiffness of transverse myelitis to directly try and relax that muscle. Separate from stiffness are the sensory issues that can happen when the spinal cord is damaged. So we focused on the motor side. How do you move? I didn't mention once the sensory side, but within the spinal cord are all the inputs coming from your body to your brain, so that when you stick your hand on a hot stove, your brain gets the signal and you know to drop some choice curse words as you remove your hand and you've scalded your hand. So when those fibers are partially disrupted, your brain only gets partial input. It doesn't get the full picture. And so when it's left with an incomplete sensory picture, it likes to make things up. It likes to fill in the gap. So sometimes people will feel burning, squeezing. Sometimes people will feel coldness. Sometimes people will feel tingling, pins and needles. And so what we do are we try a lot of different medicines. Lyrica is one, but there are a lot of others, to try and help the brain adjust to that sensory and that impartial sensory information coming in, and try and get the brain to stop making things up to fill in the gap. So what we recommend for patients who have tried one medicine but it has not helped is to work with their clinician to keep trying, because more often than not we can find a medicine that will get the job done. But it's a lot of trial and error.
Do we have any questions from the floor here? Louise?
Just to let you know, Ben, that tizanidine is still not available in Australia, which, having had the opportunity of trying it several times over the last 10 years, frustrates me enormously. But at this stage, we're still waiting until it is hopefully available at some point in the future.
Yeah, and if I want to start an illegal business, I'll just start sending shipments over to Australia. We can work out some sort of trade. We'll talk. Jim, stop the recording, and then we'll talk. So.
Later, Jim.
Ben, I also wanted to mention that early on in your presentation, you talked about the current treatments for the acute onset. Once upon a time, we always talked about steroids and then other things such as intravenous immunoglobulins and plasma exchange. Amongst therapies that are used in that acute phase, is there any new therapies that are used at that time, or are they still the sort of basis for the initial?
Yeah, those are still the pillars of what we use. We've been dabbling with some other agents here in Dallas and with some colleagues. For patients who aren't responding to the standard therapies, we have a protocol over the last several years that we just published on using a high dose of a drug called methotrexate. It was controversial because in certain cancer settings, methotrexate can actually damage the white matter of the myelin. So everyone said, well, why on earth would you use methotrexate in this setting? We've actually found that in some folks with a certain pattern of inflammation, the methotrexate does a great job of getting rid of that inflammation. So we've used that some. And then we're branching out into different immunosuppressants in very small numbers, but those are being reserved for individuals who just aren't responding to therapy the way we want. You are going to see clinical trials start up over the next year or two with new agents referred to as neuroprotective agents. So these are drugs that we're going to plan to give to patients while there's inflammation in the spinal cord to protect the axons. Because the idea is if we can regrow the myelin, all we have to do is kind of get over the hump, let the inflammation go, but we have to protect those axons. And if we can do that, then we think we'll have better recovery. So we're going to be looking at clinical trials in individuals who have inflammation in the nervous system using these neuroprotective agents.
Ben, the selection criteria for the people who will participate in your trial, will they be restricted to people who are more recently diagnosed, or will they also include people who have had transverse myelitis for some years?
Yeah, it's a great question. What we negotiated with the FDA on is this will actually include patients who are all the way out 10 years from their event. So we're not restricting to individuals who had it just within the last few months.
And the results when you tested in mice and other animals were very significant. Did all their functions return?
Yeah, so when we looked at the model we used in mice and rats, we looked in one model which had brain-based demyelination and another model looking at spinal cord. And what we saw on the brain-based was some responders and non-responders. It was about 50-50 in the mice, where half the mice recovered and regrew myelin beautifully, and half the mice had issues. And we're looking to understand why some would respond and some not. In the spinal cord, we saw significant improvements in function, but one of the things is the lesions that were created in spinal cords were on the small side, and we are going to be enrolling patients in the trial who have more significant damage. And the reason for this, and I'm very open and public about this is a safety trial, and so one of the negotiations we had to have was we had to agree on a group of patients who were so severely affected that there's little chance of us making things worse. Because we're going to do a surgical procedure. We're going to directly inject into their spinal cord. So one of the concerns from the FDA is if I take somebody who's ambulatory, who's walking, and I subject them to a procedure and they turn out worse, that was a big concern. But if I take somebody who has significant weakness and is not walking, the likelihood of me negatively impacting them is very low, but I've got a lot of room to improve. And so that's why in the phase 1 trial we're selecting individuals who are not ambulatory.
And do they have more than one treatment? Is it, so you do a stem cell injection, do they do once or is it multiple ones?
In the phase 1 trial, it's a single surgical procedure, one trip to the OR, but multiple injections during that OR trip. So we cover the size of the lesion. We directly inject into the lesion the cells. And in animals, once the cells are in, they migrate in each direction. They actually move through the spinal cord. So we know that if we inject in different spots, we can cover a large area of the spinal cord.
I've just got. Hi, Dr. Greenberg. It's Jill Bennett. Chelsea's doing very well. Thank you very much. She's moved to adults neurology now, which seems to be a lot better, or better communication. Just one question that a lot of mothers or teenagers are asking is, what do you feel about the HPV vaccination?
Yeah. Yeah, we get that question a lot. So we've gotten good data on the overwhelming majority of vaccines. So we've got good data on flu, hepatitis, measles, mumps, rubella, you name it, that we are not finding links or causation links between them. HPV is newer, so we have less data. What I can tell you is for all of the transverse myelitis patients I know who have had TM and were subsequently vaccinated with HPV or any of the other vaccines I just mentioned, I am unaware of a single case of recurrence of inflammation in the spinal cord. And so, in general, we are saying to move ahead with vaccination. Even in settings where there is a concern that vaccine triggered an inflammatory event, which is a very controversial area, and I won't go down that road today, if you take the people who really believe that that was the cause, it had to be a perfect storm of events. You're never going to step into the same river twice. And so the likelihood of somebody having a recurrent event is astronomically small, even if you believe there is a link between them. So it's not something we've seen happen, so we've been fine doing the vaccinations.
Great, thanks.
Yeah.
Suzanne.
Dr. Greenberg, Suzanne Mulligan speaking. My TM was not an acute attack. It degenerated over a period of months. And I'm now in a wheelchair. Will you be looking at people in that situation as well in your trial?
Yeah, so the key to the trial is that you've had the diagnosis of transverse myelitis, and we can confirm that that was the diagnosis. And so when somebody declines in function over more than a month, we have to explain that decline. So there are a couple potential reasons. So it is rare for inflammation to smolder for more than a month, causing just kind of stepwise decline over many months. And so it always sends up a flag for us to say, well, was there inflammation? And then we can see people decline functionally depending on what they're doing from a therapy perspective or other things. But the inflammation may be gone, but they're still dealing with after effects. Or we look for other potential explanations for the damage to the spinal cord. So to us, the timeline in and of itself doesn't change whether or not somebody can be in the trial or not, but it definitely causes us to examine the diagnosis whenever somebody is still declining after the first month. And so we always want to wrap our heads around why. So I do my version of the Spanish Inquisition in my clinic room, where I really have people go week by week and relive the experience to tell me, what could you do at the end of the first week? What could you or could you not do at the end of the second week, the third week, the fourth week? And I encourage everyone to do this exercise with their family. I'll bring 4 family members in and get 6 different answers of exactly what was going on. And it's hard to remember after being through such a traumatic event, kind of what was happening in week 1 and week 2, and when you're in the hospital, it all runs together. But a lot of times, or I should say the majority of the time in transverse myelitis, the inflammation is there and gone in the first 30 to 60 days.
I've had several MRIs to try and find my inflammation. Wasn't successful till the 7th MRI, and subsequent MRIs don't show anything either. So it was very difficult for the doctors here to diagnose what had happened to me because it was such a slow onset.
Yeah, again, when there's slow onset going over more than a month, we always, and it's always important to remember there are lots of ways to get spinal cord damage. The myelitis specifically means it's the immune system. We see a lot of patients who have other pathways to getting the damage. And so ensuring that everyone's comfortable with how the designation of inflammation in the spinal cord was made is important for every patient. What is the evidence? Because we're not doing spinal cord biopsies on everybody. We're not taking everybody to the operating room, taking a little piece of spinal cord, and then looking for those little blue cells. We're using circumstantial evidence, the MRI and spinal fluid, and the history, what what we experience, what you experience over time, to build the circumstantial case of, did inflammation commit the crime? Is inflammation the guilty party, or are we going to blame something else for the damage that was done? And so there are oftentimes, even when we talk to families after very thorough workups and say, listen, I think this was transverse myelitis. I can't promise it was. I'm going to call it transverse myelitis because your insurance company keeps calling me and they need me to give them a diagnosis. And so I'm going to give them a diagnosis. But you and I know that it's transverse myelitis with a little asterisk next to it, and I reserve the right to change this in the future as I get smarter and figure out other ways to make this diagnosis. And so whenever we have somebody where, and it can be very difficult, sometimes we put a little asterisk by the diagnosis and say, listen, we need to keep an open mind. Now, once the damage is done to the spinal cord, whether inflammation was the culprit, the criminal actor, or something else, the rehabilitation, it can be quite similar. So whether you are damaged from trauma or from blood flow issues or from inflammation, the concepts we use in rehabilitation overlap quite a bit. So in the long term, it may not change exactly what we do for recovery. In the short term, it makes a big difference in terms of what we do for treatments.
Thank you. Do we have any more questions from people who are linked in via video?
Ben, are you able to see the questions? There's 3 that were posted.
Let's see. Are they in the? Oh, I'm looking in the chat. Okay, now I see them. I have to expand my screen. Okay, so one question was, if you had the 3 days of steroids in the hospital and were discharged, can inflammation cause further damage if the steroids didn't help remove the inflammation? So what I tell my residents and my medical students and my trainees is, in transverse myelitis, your first job is to put the fire out. So if the garden hose you use doesn't work, you need a bigger hose. So if steroids don't work, you need to move on to plasmapheresis or other drugs. So in general, steroids, for most patients, will slow, stop, or reverse the inflammation, but there are a lot of patients who need additional therapy. And so everybody is different. I've had patients on steroids where they, a week later, are hop, skip, and jumping out of their bed. And then I've had patients where I've had to do a lot of things beyond steroids. And so steroids in and of themselves are not a guarantee of putting the inflammation out. And so it can be difficult to know. The second question that's on here is there still a point in regrowing myelin if the axon is damaged as well? This is from Jenny. It's a great question. And the answer is yes, because we never cut all the axons. It doesn't happen. There are always axons left intact. And so my problem is I don't know who's who. So if 2 people who've had transverse myelitis roll into my clinic, both unable to walk, one of them may have hundreds of thousands of axons that are intact with no myelin, and the other one may only have 50,000. I can't tell the difference, and MRIs can't tell the difference between those 2. So we will pursue remyelination therapy in each until we can prove who are going to be the responders or non-responders. The next question from Valerie is about medical advice around Lyrica, which she had trouble changing over. They suggested an epidural injection, and I'm frightened to go ahead with the injection for fear of becoming worse. Comment on the use of both drugs and epidural injections. So obviously I can't go into specifics about your case without the details, but in general, epidural injections are used if we think somebody has an arthritic pain in the spine. So the key is the diagnosis. If somebody has a facet joint, which is the joints of the spine that is inflamed and causing pain, epidural injections are perfectly reasonable and safe to do after a spinal cord event. The risk to somebody with transverse myelitis is no different than the risk of anybody else getting an epidural injection. The key is making sure it's indicated. So you have to spend time talking to your clinicians about what kind of pain you have. My patients have often 2, 3, or 4 different types of pain all going on at the same time. They may have burning pain in their feet, muscle ache pain at their back, muscle tightness pain in their thighs, and if they come in and they say, Dr. Greenberg, I still hurt, and I just prescribe one drug, there's no one drug that's going to cure all 3 of those things. And so you have to spend time breaking down the different types of pain you have because they may require different treatments. Lyrica is great for neuropathic pain, but it's not going to do anything for an arthritic joint. An epidural injection, however, isn't going to do anything for neuropathic pain, but it would help with an arthritic joint. So you have to break down the pain into the different types. And then it looks like 2 more. Follow-up from the question of steroids on how do you know if the steroid is not working. They haven't had a follow-up since discharge or the results from the lumbar puncture. So it's important to get back in touch with your treating physician and let them know where you are symptomatically. And they have to decide, do they want to follow up with yet another MRI to see, is the inflammation gone or not? It is possible for the inflammation to be gone, but recovery not happening yet. And so, or it's possible for the inflammation to still be there and the recovery to just be partial. So each case is a little different. We have to decide, do we need to re-image to prove whether or not the inflammation's gone? And then the last question here is specific to rheumatoid arthritis. Is somebody with rheumatoid arthritis at a greater risk of relapse? In general, no. So just rheumatoid arthritis in and of itself does not lead to independently greater risks of relapse, but any autoimmune condition raises the concern for systemic autoimmunity for conditions like neuromyelitis optica or multiple sclerosis. And so making sure that people who have one autoimmune condition who develop transverse myelitis are tested for those other conditions are important. But in general, rheumatoid arthritis in and of itself is not a risk factor for relapse. Things like lupus and Sjogren's are much bigger risk factors than rheumatoid arthritis. So I think I cleared out those questions.
Okay.
I just have one more question, Dr. Greenberg.
Yeah.
It's Ross Duncan from Spinal Life Australia again. One of the other groups of people that we work with quite closely are survivors of polio. When you mentioned damage to locomotor neurons and sprouting of motor neurons again, it seems to be a commonality between both groups, TMers and people living with post-polio syndrome. That's taken into account when allied health professionals and GPs are prescribing rehab treatment for hydrotherapy or gym-based rehab in post-polio patients. Is that also an important consideration for people seeking treatment for TM, rehab-wise?
Yeah, so we use a lot of aqua therapy when we can get access. Access is the problem for us. You know, I think there are just too few facilities and too few therapists really trained on how to incorporate aqua therapy into the regimen. The beauty of aqua therapy, whether it's an upper or lower motor neuron that's damaged, is it takes gravity out of the equation. And it's amazing what a person's muscles can do when gravity is out of the equation. So what I tell my severely affected patients is you will walk in a pool before you walk on land. Even with harnesses and de-weighting systems and very fancy devices for treadmill walking, you will do more in a pool because you don't have to worry about your trunk. You don't have to worry about center of gravity. When done correctly, you can do a lot of things in a pool. And so for individuals who are not walking normally, I'll have them do aqua therapy to get their mechanics right in the pool before you try it on land. So one of my favorite facilities are pools that have treadmills in the pool with cameras in the pool and a TV monitor above, so you can walk on the treadmill in the pool and you can see your legs walking on the screen, and then they can raise or lower the height of the treadmill, because as you lower the treadmill and the water goes higher to the chest, it's easier to walk. And when we want to increase the difficulty, we raise you up and make you start doing more of the work and controlling more of your trunk. and that's where we can change how hard it is. And so aqua therapy in the post-polio world and in the world of transverse myelitis is a wonderful tool to use, and we encourage everybody who has access to get into a pool.
So, slight follow-up to that, is there the possibility of damaging those sprouts with overexertion or higher degree of difficulty of exercises attempted?
Yeah, this has been a theory that's been batted around for literally about 100 years now, and we don't think so. So at physiologic rates of firing, we do not think you can damage, even if you go to exhaustion, we don't think you can damage a sprouting neuron. There's a higher controversy around direct current electrical stimulation of muscle that's been denervated, and what are the pros and cons of that. But through physiologic work, anything exercise-based, I have not found any data to say that it'll actually inhibit recovery. And so we tell people, listen to your bodies. The real problem with exhaustion, quite frankly, is people stop mechanically doing things right. They don't listen as intently to a physical therapist. They start to swing their leg a little bit more, and that scares me more than anything else. And so I don't think there's a harm, even as that sprouting is occurring.
We've got a physiotherapist sitting at the back of the audience nodding profusely.
Well, wait, are they nodding up and down, or are they nodding like this?
It's a good nod, nodding up and down.
Okay.
So, were there any other questions from the room? Yeah.
Ben, I'd just add to that discussion on hydrotherapy. That was my favourite form of therapy because it not only helped me get mobile and feel more confident that I wasn't going to fall over, or if I did, it was, not any serious consequences. But it also helped me sleep a lot better and improve my pain level. And I got some friends involved, so it became a social event. So just to get the word out there, it is a good form of positive sort of effort you can do towards recovery, but you can make it a social or an enjoyable event. When we live in a climate such as Brisbane, where it's,
summer all year round.
Yeah. So I just wanted to add that to your sort of discussions on it, on the risk.
Yeah.
We have.
It's always a good thing.
Yes, Dr. Greenberg, with Anthony here, the physiotherapist that was just recently referred. I just want to say thank you. Lots of great comments and perspective on rehab in general. And it's really fantastic to hear the coordination between different disciplines is essential, especially with such a complex presentation for a lot of patients. I've had the fortunate opportunity to work both at the acute center or acute stage of it in the hospital rehab, like post-diagnosis, all the way to now working out in the community. And one thing I can comment on that I think needs to occur a little bit more inside the hospital system is the discussion of the longevity of rehab. I found a lot of people who are first and newly diagnosed, there's a particular kind of immediacy in their mind that if I don't get this now before I leave, I won't ever get this when I'm back into my home environment or whatever. And we all want immediate results, yes, but I think there's a very small appreciation for, in many cases, the unfortunate lifelong management and recovery of this. And that's one thing that I find I spend a lot of time with my patients and clients discussing the long-term goal setting and the long-term focus of it. And, sometimes I think it's a bit affronting for some people. It can be very stressful to think of it, but I find when they circle around that, there's a lot more of kind of a track work ahead. So I'm not sure if you can comment in the US. I know that when I was working in Canada, there was a lot more of that discussion very early on.
The notion of time course is a complicated and very poorly communicated topic between practitioners and patients. I will list for you the top, let's call it 5, maybe, we'll keep track, the top list of miscommunications around timeline that occur. Number one miscommunication is whatever you get by a year or 2 years, and people fill in the blank. They make numbers up all the time. 6 months, a year, whatever it is. Practitioner will say, whatever you get at a year, that's all you're going to get. That there is zero scientific data to support that, and in fact, every study that has ever been done supports the exact opposite of that. The key is when you stop trying, that's all you're going to get. There isn't a spontaneous, outside of divine intervention, there isn't a spontaneously genetically encoded recovery. And so remember, the language your body speaks is a task-based language, not English or prayer. You have to do things in order to improve. So if I'm a physician and I tell my patient, whatever you get at a year is all you're going to get, guess what all my patients do at a year? They stop seeing the physiotherapist because I told them that's all you're going to get, so they never recover after a year. So that's the number one miscommunication. The second miscommunication that occurs is that you get better by going to see your therapist. You do not get better by going to see your therapist. You get better by doing therapy, whether your therapist is there or not. Your therapist is there to train you on how to do it, but you have to do it every day. So what I tell patients is if you win the lottery and you are vacationing in Hawaii, you better still be doing therapy every day on the beach in Hawaii, because there is a use it or lose it phenomenon after a spinal cord event. You could recover beautifully. Stop doing your therapy, you will lose function, because part of that compensation comes from repetition, 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 and so you have to do it every day. Third largest miscommunication that occurs, to your point, you are right, there is a lack of communication about longevity of recovery in hospitals. Likewise, however, I hold my therapy colleagues, their feet to the fire. There is a lack of communication in the hospital about the different types of therapy that happen simultaneously. If I take an able-bodied individual and I paralyze them, even if they're going to go to full recovery, there is a period of time where they are not walking. They have to learn certain life skills to be independent. So they have to learn how, and some of you went through this, how to dress, how to transfer, how to go to the bathroom, how to get into and out of a car. Everything changes in terms of life skills. It turns out teaching somebody how to dress themselves in a chair or transfer to a toilet or transfer to a car or whatever the case would be does nothing for recovery. It has nothing to do with recovery. Those are skills that are needed for independence. Then there's a whole host of things we're going to work on for recovery. Standing in a standing frame, bearing weight, working on a locomat, getting in the pool. Those exercises that work with a therapist does nothing to increase independence. It's going to do nothing to teach you how to move from a chair to a car. And the problem that happens with a lot of therapists, quite frankly, is when working with patients, they don't tell the patients, right now we're working on independence. What I'm teaching you right now has nothing to do with recovery. Don't worry, in the second hour, we're going to work on recovery, but you got to go home and lead your life while waiting for your legs to improve, so you need these life skills. So a lot of people leave their acute care experience feeling as though they weren't being challenged to walk again, whereas the therapists are saying to themselves, at least in the United States, well, you know, Ben was leaving the hospital in 4 weeks. He needs to know how to dress himself and live his life. And so part of the communication has to happen in therapy about whatever is being taught, the reason it's being taught. People have to understand that until you get core strength, you can't walk. People, my patients say, well, I go to the gym and I spend all this time on the mat, leaning over and picking things up and leaning over and picking things up. They never walk me. I want to walk. And we have to remind people, if your core is not strong, you can't walk. There is no walking without a core. And so the communication between our therapists and patients also has to improve around why are we doing the exercises we're doing.
Yeah, absolutely, 100% agree with that.
Okay, do we have any more questions?
Yes, there's more online, Ben.
Okay.
Woken
A couple years ago, Adam Kaplan reported a link between IL-6 and transverse myelitis. Has there been any more research on it? It turns out, so IL-6, which is one of the proteins inflammatory cells secrete, there was a paper that came out years ago showing that the more IL-6 you had, the more damage you had. most of those patients probably had neuromyelitis optica. So it turns out IL-6 is a major component of the pathway for neuromyelitis optica, and some of those patients were probably included in Dr. Kaplan's study. So IL-6 may play a role in a lot of transverse myelitis, but it may not be all. It probably plays the biggest role in neuromyelitis optica. Oh, we're saving the best for last. Dr. Greenberg, do you have any tips on how to tackle doctors who do not take the condition seriously? Yes, but this is a family-rated video, so I'm not allowed to use the language I would use. So we're going to have to communicate that in a different way. In all seriousness, though, part of this is about time and getting that human connection with your clinician. You have to find a way to get them invested. We could spend an hour talking about how you do that, but in general, you get further with niceties than rancor, even if you're angry with them. Try to find ways to connect. It's always impactful if a patient says to me, Dr. Greenberg, I really appreciate your time, but I don't think you're hearing me. That phrase is a very powerful phrase to physicians because it simultaneously says that somebody's appreciative, but they're just not feeling understood. And if a physician doesn't slow down, stop, and really listen at that point, then you really have to look for another clinician. And so if you ever feel like you're not being heard, saying that in a very disarming way, not try and hold back the anger and the frustration, and really see if you can get them to connect is a great way to try and slow things down. But sometimes, if it's just not working, you do need to just consider seeking out a new clinician, and that's where your community becomes important. Talking to other patients, other families in your community to try and find out, are there individual practitioners there who may be more in tune with these issues may be important.
Okay.
I think that's the last of the online questions and the last of the questions for the room.
Yes.
So thank you very much for your time, Dr. Greenberg. As we said at the start of the day, dedicating the day to Pauline Siegel, I think that's a pretty good example of that she would have been proud of making this connection and us continuing the connection into the future. So thank you very much for your time. I think if everyone in the audience could give Dr. Greenberg a round of applause. So I know it's 8:45, I think, on Sunday night there, Dr. Greenberg.
Yep.
And I know you must love Australians because you've got a boomerang hanging on the wall in the background.
I was waiting for somebody to comment on that right there.
I reckon it probably was a 4-leaf clover just when you got off the line to the Irish a minute ago, but thank you very much for the effort anyway.
I switched it out.
So thanks once again, Dr. Greenberg. Your time
My
is
pleasure.
greatly appreciated, particularly when you give it on a voluntary basis on a Sunday evening. So I'd like to thank you again.
Absolutely. Thanks. Enjoy your day.
Thank you very much.
Oh, Ben, we have one more question online. Do you see the last?
It's an easy one.
Wait a minute. It might be my screen is too small. Hold on.
It's not as big as Texas then.
So this the individual is talking about complex PTSD, which in the United States stands for post-traumatic stress disorder, as well as transverse myelitis. Can these two conditions be treated together? So as Adam Kaplan does a great job of talking about, there is a huge interplay between the emotional aspects and the psychology and psychiatry that goes into brain functioning and what happens to us after transverse myelitis. And so a key portion of our multidisciplinary team is working with not just physical therapists, but emotional and mental therapists, psychologists or psychiatrists, because both for the individuals and the families, there is a profound impact of the damage that happens to the spinal cord on just life and quality of life. And so it's really impossible to treat the long-lasting impacts of transverse myelitis unless we treat the emotional aspects and the mental aspects of it as well. And so both of them have to be managed simultaneously. It's a good question.
Right, I think that's it from us, Dr. Greenberg. Again, thanks very much for your time and your commitment to the cause. Thanks again.
Thank you, Ben.
Take care.